Okay, good afternoon, everyone. Thanks for logging on to this third episode of the lecture series on ATTR-CM transthyretin cardiac amyloidosis. Looking back at the past two, episodes, it amazes me that how much amyloidosis has progressed over the past 5 to 10 years. If we think 10 years ago, amyloidosis would probably be a five-slide, afterthought in a cardiomyopathy lecture, and four of the slides will be on light chain amyloidosis. Over the past decade, much has changed in the field of ATTR-CM management, and today we'll be specifically looking at the new developments in diagnosing and managing ATTR-CM from disease-modifying treatment to the modalities of imaging that we can, confidently diagnose ATTR-CM. So very interesting. This lecture is supported by an educational grant from Pfizer organized by the Singapore Cardiac Society. And I am Dr. Lim Wei Chin. I'm the cardiologist from National University Heart Center, Singapore. So some housekeeping. This will be accredited. So if you stay throughout the whole duration, you will earn, education points. And all Q&A will be towards the end of the session. Everyone can use this Q&A tab to type in your questions, but we will consolidate all the questions and we'll direct them to the speakers at the end of the three lectures. So today we have a very, distinguished lineup of lecturers, and we'll be covering the topics of general management of ATTR-CM, current disease-modifying treatments available, as well as a very bold peek into the future of ATTR-CM management. We will wrap up with, as I said, a Q&A session. So without further ado, I would like to invite the first speaker to share her slides. Our first speaker is Dr. Novi. She is a heart failure cardiologist from Indonesia, and she completed her training in Singapore. She is very active in social media. We can see her face everywhere on all the major conferences, heart failure conferences, and she's active in academia and has published lots of interesting articles on cardiomyopathies and heart failure. So Dr. Novi will be talking to us about general treatment, general management of patients with ATTR-CM. Novi, please.
Hello everyone. Can you see my slides?
Yeah, everything is good.
Okay. Good afternoon. My name is Novi. I'm a heart failure cardiologist from Indonesia. First of all, I would like to say thank you to the Singapore Cardiac Society and to Dr. Lin for organizing this webinar. Today, I will be talking about general approach of managing patients with ATTR cardiomyopathy. First of all, just a short reminder, we know that TTR, formerly named prealbumin, is synthesized in liver and composed of 4 rich monomers that circulate as a tetramer and function as a carrier protein for thyroxine and retinol binding protein. And we know that TTR misfolding and aggregation, which if deposited into the organs, leads to tissue dysfunction and the clinical phenotypes of the ATTR amyloidosis. We know that this deposition of amyloid fibril into the organs will increase over time, causing symptoms starting from neuropathy, carpal tunnel syndrome, spinal stenosis, and followed by myocardial deposition, causing arrhythmia, conduction system disease, valvular heart disease, and heart failure. And over the past decade, there is an increased recognition that many ATTR patients were previously undiagnosed and instead presumed to have hypertensive heart disease, HFpEF, or hypertrophic cardiomyopathy. So we know that main goals of therapy for cardiac amyloidosis actually includes 2 of very important things. First is the treatment and prevention of complications. And then second, to stop and delaying amyloid deposition by specific treatment. And we can see at this table, actually, when it comes to treatment of cardiac amyloidosis, the earlier the better. Early diagnosis is paramount to achieve stability and slow the progression of the disease. We could see here that in this graph, late diagnosis equals to progressive heart failure. And if you're too late, you might face the point of no return where we need palliative care or advanced heart failure therapy. Before we deep dive into the management, there are several things to consider. First, the pathophysiology and hemodynamics in patients with cardiac amyloidosis. As I mentioned earlier, once the amyloid fibril deposited into the heart muscles, it will cause a restrictive physiology where LV becomes rigid and non-compliant, causing an impaired diastolic filling and increased filling pressures. And over time, chronic elevated LVEDP might induce pulmonary hypertension and might exacerbating RV failure, particularly when the right ventricle is already involved. And LVEF might preserve in early disease, but may deteriorate over time. Hence, we might use longitudinal systolic function, which is often reduced early before the ejection fraction. And LV struggles to fill adequately despite a preserved EF, and often complicated by increased wall thickness and further restrict cavity size and reduce stroke volumes. Hence, there is some adaptive responses and clinical implications. First, there will be an increased heart rate to increase cardiac output, which again, in cardiac amyloidosis, this might be blunted due to autonomic dysfunction, which is cause hypotension. And second, there will be atrial remodeling, which cause atrial fibrillation, which further impairs atrial contribution to LV filling. And then the duration of diastole and increased LV filling pressure have relatively limited impacts on the amount of ventricular filling. And basically, stroke volume is virtually fixed, and cardiac output is crucially dependent on heart rate. And because the main problem is amyloid deposition in the myocardial, reverse remodeling is not our main therapeutic goal. So we divide our treatment goals and prevention of complication into three main categories: heart failure, arrhythmia, and valvular heart disease. When it comes to heart failure, maintenance of euvolemia is central to management of ATTR cardiomyopathy, which might include sodium restriction and diuretics. And we know that loop diuretics with higher bioavailability, such as tosomate or bumetanide, are preferred for their potency and higher bioavailability compared to regular furosemide. And it might often combine with aldosterone antagonists for synergistic effects. And for refractory congestion, outpatient IP diuretics might be useful. There is also, we might face some challenges, including the reduced ventricular capacitance, and coupled with age-related vascular changes and autonomic dysfunction, with again increased load liability. Dietary indiscretion can quickly lead to volume overload, and we might also not to overly aggressively diurese our patient because it associated with symptomatic hypotension and worsening renal perfusion. And for monitoring, outpatient PAP monitoring can be useful, though specific data for ATTR cardiomyopathy is limited. And remote monitoring strategy is potentially effective due to the critical need for precise fluid balance within a narrow therapeutic window. There is some precautions needed in some drugs. First is non-dihydropyridine CCB, which is drugs like verapamil should be avoided due to risk of heart block and shock. This is reported in studies in AL amyloidosis. And then use of ACE, ARBs, and ARNIs is often not well tolerated due to induced hypotension. And high dose of beta blockers, especially those with alpha blocking properties, can be poorly tolerated because it will blunt compensatory heart rate increases needed for maintaining cardiac output. And in advanced cases, there will be decline in ventricular capacitance, again, further leads to lower stroke volume and cardiac output, reduced blood pressure, which further necessitate the increased heart rate to maintain organ perfusion. And postural hypotension is common in hereditary TTR with autonomic neuropathy. Treatment might include midodrine, droxidopa, and compression stockings. I would like to show you the study published last year in European Heart Journal. You can clearly see here that out of more than 1,000 patients given beta blockers, 22% had to discontinue the medication, with 9% need to be reduced. Using a propensity score match analysis, they found that in patients with EF less than equal to 40, low-dose beta blockers was independently associated with reduced risk of mortality, with no difference in terms of survival of overall population and patient with EF more than 40. In ACE or ARBs category, almost 33% of drugs had to be discontinued with no convincing difference in terms of survival. In MRAs, however, only 7.5% of population had the drug discontinued, and then the analysis demonstrated that treatment with MRAs independently associated with a reduced risk of mortality in the overall population and in patients with EF more than 40. How about the use of SGLT2 inhibitors in this population? So we got that this study published just recently in JACC. It's not a clinical trial. 2,000 patients with ATTR-CM, they did a 1-to-1 ratio. 220 patients was given SGLT2 inhibitors, while the other did not. And they found that SGLT2 is well tolerated with only 4.5% discontinuation over 28 months. And they found that SGLT2 inhibitor is well tolerated and also cause a slower decline in EGFR, lower NT-proBNP, lower loop diuretic requirement, and also stable blood pressure profile. It also associated with low all-cause mortality, lower cardiovascular mortality, lower heart failure hospitalization, and a combination of both. Arrhythmia in ATTR cardiomyopathy span the spectrum from arrhythmia to atrial and ventricular tachyarrhythmias. And atrial fibrillation is the most common one. Reported prevalence is highly variable, ranging from 15 to 70%. And there is a higher prevalence in ATTR wild type compared to AL or hereditary, and potentially as high as 70% in some case report. And due to the high prevalence of atrial fibrillation, screening should be considered in this population. And the detection of atrial fibrillation actually will change our practice and treatments because the anticoagulation is essential owing to high prevalence of intracardiac thrombus. And in addition, this patient must be anticoagulated irrespective of CHA2DS score due to high thrombus risk. And additionally, TE-guided direct current cardioversion is crucial to exclude thrombus, even if the patient is on anticoagulants. And there is insufficient data on VKA versus DOAC for oral anticoagulation, and the role of LAAC devices is unknown at the moment. Rate control could be challenging due to a narrow range of heart rate to optimize hemodynamics, and we must use beta blockers cautiously, and non-dihydropyridine CCB are contraindicated. Low dose disc may be used with close monitoring for rate control and especially suitable for patients prone to hypotension. For rhythm control strategy may be considered, particularly for is effective in earlier stages of the disease, and amiodarone are generally commonly used, though there is no survival benefit noted between rate versus rhythm control. And TE-guided direct current cardioversion has similar immediate success rates, but high one-year recurrent rates. For the catheter ablation, there's also limited data. There is the long-term success rate tend to be lower compared to the non-amyloid patients. And TTR amyloid fibrils can often infiltrate conduction systems, leading to significant need for permanent pacing. And Holter monitoring is recommended for symptoms like syncope, presyncope, or palpitation. And standard standard indication for pacing requirement is according to the guidelines. And generally, bi-V pacing may be favored to mitigate dysynchrony, especially if the pacing is indicated. And then for ventricular arrhythmia, actually there is a study said that asymptomatic non-sustained VT is frequently detected, but the utility of ICD for primary prevention is still controversial, especially if the anticipated survival of ATTR cardiomyopathy is less than 1 year. And additionally, the study found that sudden death in AL amyloidosis often result from electromechanical dissociation, suggesting a limited role for ICD primary prevention. However, secondary prevention with ICD is considered reasonable, and the decision should be tailored and individualized according to our patient's need. For the valvular heart disease, we know that aortic stenosis frequently coexists with cardiac amyloidosis, especially in older adults, which almost 15% of TAVI patients showing sign of ATTR cardiac amyloidosis. And TAVI is generally preferred over SAVR, and aortic valve intervention generally shows superior outcomes in preventing death compared to medical therapy alone. However, the data reducing morbidity are still limited. And however, despite the survival benefit of TAVI, patients with ATTR cardiac amyloidosis with severe aortic stenosis will face nearly a 2 times greater risk for mortality compared to those with AS alone. And ATTR-CM also associated with increased risk for heart failure hospitalization post-procedures. For mitral and tricuspid valve disease, the surgical and interventional data for MV and TV in cardiac amyloidosis are still scarce. There is a single center study detected amyloid in less than 1% tissue of patient undergoing mitral valve surgery. And then PMVR is technically feasible in a small, carefully selected cohort of patients, including those with ATTR without adverse effect of prognosis. However, the data for intervention in tricuspid are still lacking. Just would like to show you this study published in European Heart Journal, 200 patients more than 75-year-old referred for TAVI. They found 13 patients had amyloidosis. And in this study, they found that at a median follow-up of 19 months, there are no more mortality difference, and also no difference in peri-procedural complication. However, patients with AS and amyloid will benefit from TAVI compared to medical therapy alone. And this table beautifully summarizes all the key points that is needed to be addressed. For heart failure, maintain euvolemia with diuretics, cautiously use beta blockers, might avoid ACE or ARB if hypotension. And then LFAT is generally not suitable for most of the cases because of the small cavity size, and heart transplant in selected cases. We need to consider aortic stenosis in patients with cardiac amyloidosis, and then generally TAVI will improve outcomes compared to medical therapy alone. Thromboembolism is high risk and common, and we should anticoagulate all patients if there is atrial fibrillation, irrespective of CHA2DS scores. Conduction disorder, we might consider CRT if the high pacing burden is expected. For ventricular arrhythmia, ICD is generally for secondary prevention, while a use for primary prevention is still limited. So we know that in the last decades, research have been focused on disease-modifying drugs that act through different mechanisms. First is the inhibition of the amyloid synthesis, the decrease of the TR production, and then second, the stabilization of the native tetramer structure, and then the removal of the misfolded protein. And we can see here from this timeline that there are a lot of emerging targeted therapy for ATTR-CM. I will not talk much on all of these drugs because there will be the following speaker will talk about this. First, we might have a ATTR silencer, a small interpreting RNA, patisiran, reflusiran. Although the reflusiran edible trial was stopped early because of side effects. And then ATTR silencers, antisense oligonucleotides, including anotesan and eplontersen. Eplontersen is cardiotransform trial. And then ATTR stabilizers are mainly consisted of selective and non-selective. Selective is tafamidis. The famous trial is ATTR-CM, and then acoramidis is ATTRibute-CM. And then non-selective, which is diflunisal. We also have ATTR degraders, such as doxycycline UDCA or UDCA, monoclonal antibodies, such as PRX004 or RI006, and then the future gene editing. So last couple of my slides, I would like to talk a little bit more on the use of off-label drugs. First is diflunisal. It is actually originally an NSAID and had been repurposed as a TTR kinetic stabilizer. So diflunisal is function by binding within the two thyroxine binding sites. And the clinical experience and tolerability primarily from open label single center studies. And they found that administration of 250 milligrams twice daily is generally well tolerated, though some subjects might experience side effects such as thrombocytopenia and renal dysfunction, since it is an NSAID. This is the study, a very small study. They found that the diflunisal administration was safe. However, there is no associated with significant changes in cardiac structure, function, or biomarker. And generally, for the efficacy and safety, it shows survival benefit comparable to that of tafamidis, although it's a non-randomized study. And despite being used with oral anticoagulants, significant bleeding has not been reported, likely because the selective nature of patient cohort in the study. And then the dosage used in ATTR stabilization with diflunisal is lower than the use for anti-inflammatory dose, which is might have a low observed toxicity. There are some usage consideration because it is an NSAID. It's restricted to patients without significant renal dysfunction with eGFR more than 45, no thrombocytopenia, not in failure, not in high-dose diuretics, not having recent AKI or hemodynamic instability, and must not have consumed any other NSAIDs to prevent this interaction. And then we might give PPI to reduce the risk of GI bleed, and we need to careful monitoring for renal function and volume status and GI bleeding. Second drug is doxycycline and UDCA, or Tauro counterpart UDCA. Doxycycline is a broad-spectrum antibiotics, disrupt TTR fibrils in transgenic mice, leading to decrease in amyloid-associated markers such as serum amyloid protein and MMP9. And UDCA is effective in reducing non-fibrillary TTR levels and have demonstrated a synergistic effect when used in combination with doxycycline. There are several small clinical studies have investigated the efficacy, and despite the promising clinical result, this study have not shown any demonstrable benefit in human subjects associated with ATTR-CM. And it also associated with high rate of discontinuation because of GI side effects of doxycycline, and adverse effects significantly impact the patient adherence and overall feasibility of the treatments. And so this is the study. So basically, they found that combination of Roxy and UDCA will stabilize the disease for at least 1 year. However, there is no changes of NOAA class or NT-proBNP, and there is a high discontinuation rate because of the side effects. The third is EGCG, which is catechin found in green tea. They found its potential to inhibit the fibril formation in ATTR in animal studies. It's still in a single center study involving only 19 patients with ATTR-CA observed for 12 months. There is found that there was a notable absence of disease progression. And the follow-up for 14 patients showed a mean decrease in LV myocardial mass by 12.5% and an increase in mean mitral annular velocity by 9%. And again, suggests other small single-arm studies have reported similar improvement, but we need a bigger study for this. Curcumin is derived from spiced turmeric, has shown a neuroprotective effect in ATTR by stabilizing ATTR at the thyroxine binding site. And in mouse models, the chronic administration of curcumin led to a reduction in tetramer dissociation and inhibit the aggregation of amyloid fibrils. And despite promising results, the use of curcumin in clinical setting is still limited because of short half-life and poor tolerability in high doses. Liver transplantation has been used to treat hereditary ATTR by removing the source of mutant TTR production. And while it's effective, the decreased progression might still occur due to wild-type TTR depositing on existing mutant ATTR fibrils. And the use of liver transplantation has significantly declined due to the development of new drugs such as TTR stabilizers. In the case of advanced ATTR-CM, whether hereditary or wild-type, an autotrophic heart transplantation may be considered for selected patients. This may combine with liver transplantation in certain cases. And however, there is some limitation, including the organ shortage and then patient demographics. We know that patients with ATTR-CM are generally older, which can have complicate the feasibility and the efficacy of transplantation. For the take-home messages, we know that the early identification is very crucial to achieve a stability and improve survival. And restricted physiology might increase the symptoms and cause less effective response to the treatment at the later or advanced stages. And it's really important to maintain euvolemia in heart failure with ATTR, symptom of heart failure, arrhythmia, and also valvular heart disease. And usual heart failure medication might not work for all and should be tailored according to our patients. And anticoagulation is necessary in AF regardless of Jaffa score due to high thrombus rate. There are a lot of emerging new therapy, however, cost might be the burden. And off-label drugs such as diflunisal, doxycycline might be useful in limited setting with careful monitoring of adverse effects. I think that's all. Thank you.
Thank you very much, Novi. So moving on, our next speaker is Dr. Koo Chun Yuan. She is a consultant cardiologist and in-house amyloidosis guru at the National Heart Centre, Singapore. She is, my partner in crime in many initiatives in transthyretin cardiac amyloidosis and has been critical in pivotal, I would say, in allowing this tafamidis to be listed as a subsidized drug in the Singapore healthcare system. So she's going to talk to us about the current approved treatment, disease-modifying treatments for ATTR-CM. So Chun Yuan, please. Hi, Chun Yuan, I think you're muted.
Hey, sorry. So thanks, Wei Jing, for the kind introduction, and thank you to the organizers for the kind invite. Good afternoon, everyone. I'm excited to be presenting today on disease-modifying treatment options in transthyretin cardiomyopathy. And to echo what Wei Jing said, perhaps it was not so long ago that I would say actually there are not too many options available, but I'm glad to say that the situation is very different today. So I'll be presenting on the current available disease treatment options in transthyretin cardiomyopathy, as well as the evidence behind them. So Dr. Novi has shown this very nice timeline of clinical trials in transthyretin amyloidosis, ATTR-CM was the first randomized controlled trial studied in transthyretin cardiac amyloidosis patients. And since then, several other trials in cardiomyopathy have been released, including the ATTRibute-CM, the APOLLO-B, as well as the HELIOS-B trial. So you will see this diagram a lot in the talks today, I believe. So because it is super important to understand the pathophysiology of transthyretin amyloidosis, because each treatment actually targets different steps of the pathway. So the protein, the culprit protein is actually the transthyretin protein produced by the liver. It exists as a 4-part protein, but because of genetic mutations or aging, this 4-part protein becomes unstable, breaks down into monomers, which clumps together into sticky amyloid fibrils that causes disease. And when it attaches to the heart, causing the heart to be thick and stiff, it causes the transthyretin cardiomyopathy, a restrictive form of cardiomyopathy at the beginning. Now, the rate-limiting step of this disease process is actually the dissociation of the transthyretin tetramer protein. And so we have the stabilizers. So we have heard Dr. Novi speak about diflunisal, which is a non-selective stabilizer. And I'll be touching on the selective stabilizers, tafamidis and acoramidis. So these stabilizers stabilize the tetramer complex and thus reduces the formation of unstable monomers, thus reducing the formation of sticky amyloid fibrils. We also have silencers that reduce the transthyretin production from the liver that have been studied in cardiomyopathy, namely patisiran as well as vutrisiran, which I will also be touching on in my talk. So the evidence. So ATTR-CM, the first randomized controlled trial in transthyretin cardiac amyloidosis, it was studied in patients with ATTR-CM, with a history of heart failure hospitalization in the past year or clinical evidence of heart failure. And it was shown that tafamidis significantly reduced the combination of all-cause mortality and cardiovascular-related hospitalization with a relative risk reduction of 30%. Impressively, the number needed to treat to prevent 1 death at 30 months is actually 7.5 only, which is very remarkable for a cardiovascular trial. There was also reduction in deterioration of functional capacity measured by 6-minute walk distance and reduction in deterioration of quality of life measured by the KCCQ overall score in this trial. So in this post-hoc analysis of the ATTR-CM trial, they studied the serial echo performed during the ATTR-CM study, and they found that tafamidis actually attenuated the decline of LV systolic and diastolic function measured by echocardiogram parameters over 30 months. So these parameters included LV ejection fraction, LV stroke volume, LV GLS, as well as sector E over E prime. So importantly, this same echocardiographic parameters also play a part in prognosis of the condition. So acoramidis is a 2nd-generation stabilizer. It mimics the super stabilizing mutant, the T139M mutant that causes the transthyretin tetramer to be stable. So in the ATTRibute-CM trial versus placebo, acoramidis actually reduced the 4-step hierarchical combination of all-cause mortality, cardiovascular hospitalization, NT-proBNP, as well as 6-minute walk distance with a win ratio of 1.8 over placebo. Now we've seen tafamidis and acoramidis, which are the selective stabilizers, and their evidence in transthyretin cardiac amyloidosis. Now, what about the silencers? So the silencers, patisiran, vutrisiran, and also eplontersen, they have actually been already FDA approved for treatment of peripheral neuropathy indication. But in this peripheral neuropathy trial, the APOLLO-A trial for patisiran and HELIOS-A trial for vutrisiran, they actually saw benefits seen in a cardiac subpopulation. And hence the APOLLO-B study for patisiran and HELIOS-B study for vutrisiran were carried out in cardiomyopathy patients, both with variant and wild-type ATTR. So patisiran is actually given intravenously every 3 weeks, while vutrisiran is a subcutaneous administration every 3 months. So in the APOLLO-B study, patients in the patisiran group actually showed preservation of functional capacity. There was less reduction in 6-minute walk distance. So from the graphs, it's actually the blue line. And then, so this represents the treatment group and this represents the placebo group. There was also an improvement in 8-KCCQ seen in the patisiran group, as well as stabilization of the cardiac biomarkers. So this trial did not meet the secondary endpoint of a composite of cardiovascular events as well as all-cause death, although it was in the right direction. And of course, the recently released HELIOS-B trial showed that vutrisiran reduced the composite risk of death and recurrent cardiovascular events for transthyretin cardiac amyloidosis patients compared to placebo. Significantly, 40% of patients in this trial were on tafamidis given concurrently, and 20% of, during the trial, 20% of patients in each subgroup was actually started on tafamidis. Regardless, this trial showed that the benefits of reduction in death and recurrent CV events actually applied to the patients, regardless of whether they were on or not on tafamidis. So when should we start this disease-modifying agent? So I would say that we should start them as early as possible. So evidence for this early initiation of treatment can be seen in the contemporary ATTR cardiomyopathy population seen in recent trials, and also the long-term extension study that have been published so far have shown us that time lost is survival, functional capacity, and quality of life lost. So in this table, due to greater awareness of the condition, non-invasive diagnosis, patients have been diagnosed earlier and earlier in their disease stages. So in this table, we could see that the trial population in the later trials, the ATTR-CM and HELIOS-B trial, were actually at earlier stages of disease or less unwell compared to patients in the initial ATTR-ACT trial. So you could see that the survival rate for the placebo group in the ATTR-ACT study at 30 months was only 57% compared to 74% of the placebo group in the ATTRibute-CM and HELIOS-B trial. There was also a greater number of patients in better functional class status of NYHA class 1 and 2 in the ATTRibute-CM and HELIOS-B trial compared to the ATTR-ACT trial. The reduction in 6-minute walk distance and quality of life for the placebo group of patients in the ATTR-ACT trial were also significantly more than patients in the HELIOS-B and ATTRibute-CM trial. And furthermore, the median NT-proBNP of the ATTR-ACT population is also higher than the NT-proBNP in the other two trials. But we have seen from the ATTRibute-CM and HELIOS-B trial that regardless of this, although the patients in these trials are at earlier stages of disease, the mortality and morbidity benefits still applied to them. And TEOS registry is actually a is actually an international amyloid registry comprising of all transthyretin amyloid patients as well as gene carriers. So 33 countries patients are actually enrolled in this registry, and they were studying real-world patients with or without treatment and their outcomes. So for the cardiomyopathy cohort of the TEOS registry, we could see that their population actually resembled more of the ATTRibute-CM and HELIOS-B trial and were generally less sick compared to the ATTR-ACT trial. So we can see that the survival rates, the proportion of patients with NYHA class 1 and 2, the median NT-proBNP were closer to the values seen in the ATTRibute-CM and HELIOS-B trial compared to the ATTR-ACT study. So in this study, for the cardiomyopathy cohort of the TEOS registry, they saw that even though the patients were at earlier stages of disease in this real-world cohort, those who were treated with tafamidis had better survival benefits compared to those who were not on tafamidis treatment. So we can see in this graph, tafamidis treated patients being in red and the tafamidis untreated patients being in purple. So this is a graph from the ATTR-ACT study. Survival probability was being studied. So those who are on tafamidis is in red, and those in the placebo group is in blue. And we can see that the survival curves between the treatment group and the placebo group start to diverge at approximately 18 months. The trial came to an end at 30 months, and after that, patients in the tafamidis group were allowed to continue on this long-term extension study up to 60 months or about 5 years. And those who were in the placebo group, blue group, were switched to tafamidis at 30 months. We can see that after the switch, those who were in the placebo to tafamidis group never reached the survival benefits that the continuous tafamidis group had. We could also see, comparing the blue line to the extrapolated placebo group, that there was a stabilization of, there was some benefits seen in the placebo to tafamidis group at month 45. And in general, this placebo to tafamidis cohort performed better than extrapolated placebo. So a similar findings were seen in the acoramidis open label extension. So similarly, at month 30, patients who were in the acoramidis arm continued on acoramidis, while patients in the placebo arm were allowed to switch to acoramidis. So we can see that the survival benefits never ever recovered to that as compared to patients who receive acoramidis continuously. And a similar trend was actually observed for NT-proBNP, KCCQ, as well as 6-minute walk distance. So the survival benefits, the functional capacity, the quality of life actually never recovers for patients who started on treatment later. And the APOLLO-B open label extension study also showed us the same. At month 12, after the trial ended, patients in the patisiran group continued on patisiran to month 18, and patients in the placebo group were switched to IV patisiran. So we can see that the functional capacity and KCCQ of patients in the placebo to patisiran switch groups stabilizes, but never ever recovers to that of the continuous treatment group. So in summary, we have seen that for treatment, for amyloid-specific treatment, the earlier the better, and it is also better late than never, because the patients who are switched perform better than if they remain on placebo, as seen in the comparison with the extrapolated placebo curve. And what about the safety profiles of this amyloid-specific treatment? So for tafamidis, acoramidis, patisiran, and vutrisiran, they were all shown to be relatively tolerable with acceptable safety profile compared to placebo in all their respective phase 3 randomized controlled studies. So coming to the end of my talk, in summary, the amyloid-specific treatments do work. They reduce mortality and cardiovascular events as seen in a trial for tafamidis, acoramidis, and vutrisiran. They preserve functional capacity, quality of life, and stabilize biomarkers of the patients. And they result in favorable cardiac remodeling and imaging parameters for these patients. So I think the take-home message, early diagnosis and early treatments, and the earlier we start the treatment is better. And if we do not start the treatment early, it is also better late than never. So the current scene in the world and Singapore, tafamidis was approved by FDA for treatment of transthyretin cardiac amyloidosis in 2019, and is also HSA approved for treatment of transthyretin cardiac amyloidosis since 2020. So acoramidis has recently received FDA approval this month. HSA unclear because we are not sure whether or not this drug will be available in Singapore. Patisiran, because of the relatively weaker primary endpoint, FDA did not approve it for cardiomyopathy indication. So currently, patisiran is only used for peripheral neuropathy indication. Vutrisiran is currently awaiting FDA approval, and so HSA approval will likely follow after FDA approves. So with that, I end my talk and looking forward to the discussion ahead. Thank you.
Thank you, Chun Yuan, for bringing us through the treatment landscape today for cardiac amyloidosis. So it is very important to remember that current therapeutic options we have seem to be only able to delay disease progression. There has never been something that can reverse the damage done to our patients' cardiac function. So it's something that we are very cognizant about. And we hope in the future we can do something different to improve the patient's outcomes on top of this current treatment options we have. So for the last speaker, I'm very happy to have with us Associate Professor Nicole Butt. She is a cardiologist, heart failure cardiologist at the St. Vincent's Hospital, Australia, and she's currently a visiting, academic at the Brigham's Hospital, Harvard Medical School. I last checked, it is about 2 a.m. in Boston, so I'm very grateful for Nikki for logging in despite the time difference. I first met Nikki a couple of years ago in an amyloid conference, and I've been very impressed with her work in the research and education to healthcare professionals and patients alike in the field of cardiac amyloidosis. So she will be sharing with us today the peek into the future of cardiac amyloidosis management, both in diagnostics, how we are able to maybe one day diagnose patients earlier, plus what are the new medications in the pipeline for the treatment of our patients. Nikki?
Hi, everyone. Thanks for the opportunity to be here today. Thank you, Dr. Lin, for that wonderful introduction. It was very nice to get to meet you in person and now continue to work with you. It's fabulous to see so many people online to talk about cardiac amyloidosis. So thank you for the Singapore Cardiac Society for putting this together. So as Dr. Lin mentioned, I've got the privilege of talking to you about a peek into the future of ATTR management. And there's a lot to be excited about. As we've already heard, the space has moved so quickly over the last decade. And really, we're looking at a disease where, not that long ago, when a patient was diagnosed with cardiac amyloidosis, the treatment was essentially supportive care, to now having not just one, but a range of disease-modifying therapies. There's a real imperative to learn about amyloidosis and to work out what's the best therapy for your patient. So the first thing that I'm going to talk to you about is the future of amyloidosis multimodality imaging. Now, the first thing to say is that the guidelines globally are moving towards non-invasive diagnostic criteria. So as a quick summary, you have your red flags for cardiac amyloidosis, which include left ventricular wall thickness greater than 12 millimeters, and then, heart failure symptoms. You might have symptoms like aortic stenosis or autonomic dysfunction. And then this diagnosis panel from the ESC criteria, where ideally you do simultaneous bone scintigraphy and blood and urine tests, and you're able to make a non-invasive diagnosis if there's a positive bone scintigraphy with negative blood and urine for AL amyloidosis. And then treatment, which we've already heard a little bit about. But beyond this, there are a number of unanswered questions for treatment. So, we've already heard you've got to be diagnosing these patients early, but how? How do we diagnose them early so we can get them onto treatment? What are the markers of early disease? How can we move towards a fully non-invasive workup? Because there is about 30% of patients who still have abnormal blood and urine tests, as well as an abnormal bone scan. And what do we do with some of these patients? How can we quantify amyloid load? And how can we determine the cardiac response to therapies? So this is a review article from Jack, and it summarizes nicely some of the multimodality imaging approaches to amyloidosis. So bone scintigraphy, there are a number of things in development. For echo, echo is our workhorse. So again, there are spaces where we are able to develop our echo paraphernalia, and then MRI, which is not part of the standard workflow for amyloidosis, but which can increase our understanding in a number of different ways. And then PET. So I mentioned that echo is our workforce. it's workhorse, it's widely available, and it's usually the first test that patients have. And we know that there are the typical pattern for amyloidosis. So these patients might have increased wall thickness, they might have a sparkled or speckled pattern, they might have apical sparing. But we're moving towards increased ability to diagnose patients early, and strain, and that's multi-chamber strain, has become important in terms of early disease. So this is a paper from Scott Solomon comparing control, so patients without amyloidosis, with amyloidosis with a dilated left atrium, with those with a non-dilated left atrium, and you can see you have a very different atrial strain pattern here. So this may become an important tool as we start to screen patients. In addition, there's regional strain. So we know that there's this classical apical sparing pattern, but that doesn't happen in everyone. And also that may not be the best way of monitoring disease. So this is a sub-study from the Apollo study, which you heard about earlier. And here they showed that with treatment, patients actually, their basal region, they had the best response to treatment. So that's interesting because if we're not looking in the right area, we may not see the right response to treatment. And so understanding that amyloidosis, it deposits in different areas and may deposit in different areas differently, helps us then monitor treatment response. Next, PET is not part of the diagnostic algorithm at the moment, but PET radio tracers are super exciting. So the first radio tracer that was available was CPIB, but it had a short half-life and you needed on-site cyclotron. And now we've got these F18 tracers, which they're commercially available in brain imaging, but they don't require a cyclotron. And in fact, they may be helpful in subclinical disease. So these are being developed and may help us differentiate between subtypes. So we may be able to see what is ATTR versus what is AL in those cases where it's difficult to distinguish with our standard multimodality imaging, and it may be able to help us understand amyloidosis load. Here's just a beautiful diagram from Shamila Dorbala, who's really leading this space in terms of PET tracers, showing how the tracers light up in terms of systemic amyloidosis and cardiac amyloidosis, and maybe a way in which we can monitor response to therapy. And here is one of those tracers that we mentioned, the flabetapir, and you can see in AL amyloidosis, it's got important prognostic potential where you can use it for serial monitoring. And so I think that this is definitely I was asked to give you a peek into what might be the future. At the moment, there are issues in terms of how do you access a PET scanner, particularly when we have patients that struggle to have access to, care, rural or regional patients, cost, and training people in terms of their reading of PET. But it's definitely an interesting space to be aware of. I think the next, sneak peek into the future is AI, and it is everywhere now. And amyloidosis, was previously classified as a rare disease. We're understanding it's not as rare as we previously thought. But AI has the ability to help us diagnose patients early because there are a number of studies, including AI screening for 12-lead electrocardiography, where we're able to combine ECG plus medical records, particularly when you've got electronic medical records. And we're able to identify patients who may be at higher risk of amyloidosis. In addition, in combining AI, ECG, and echo, so this is a multi-center study where they showed that this algorithm was able to very nicely pick up amyloidosis. There are also AI tools for automation of echo and for pointing sonographers and clinicians towards the diagnosis of amyloidosis. So I think that this is absolutely a watch this space and something that is going to very rapidly develop. So what about the future of amyloidosis therapeutics? This is a hugely, hugely, hugely exciting space. So we know already from the talks you've heard today that there are three main ways in which the amyloidosis disease-modifying therapies work. So you either suppress the amyloidogenic TTR, you stabilize it, or you actually degrade the fibrils. So I think the unanswered questions in this space is, first of all, which drug? And some of that is limited by cost and by region. And then second of all, we now have access to tafamidis in a lot of countries. So is it better to be on a silencer or a stabilizer? And for patients that are already on tafamidis, should they be on a second agent? And what is the risk-benefit as well as the cost of that? And then as we get better and better at absolutely knocking down transthyretin, are there any long-term effects? So we heard a little bit about the class of drugs, including inotersen and eplontersen. So this is the NeuroTransform study, and this is from the Journal of Cardiac Failure. It's the only cardiac study at present on eplontersen from a neuropathy cohort. And you can see here this early signal that eplontersen actually, you have an improvement in ejection fraction and you have an improvement in stroke volume. The CardioTransform is currently enrolling patients, and this will look specifically at a cardiomyopathy cohort. And what's incredibly exciting about this is that patients predominantly are on tafamidis. They're not restricting patients on tafamidis. And so we'll be able to see what happens with a combination of tafamidis and eplontersen. In addition, they're stratifying across a range of New York Heart Association class and other subgroups. And as mentioned earlier, patients are already on therapies such as SGLT2 inhibitors. So we're getting better at making sure that patients are picked up earlier and such that they're not as sick when they're enrolled in these trials for the most part. So it will be very interesting, the results of this CardioTransform with the use of eplontersen. Next, the CRISPR-Cas9 technology, amyloidosis made the headlines when the first 7 patients had gene editing for TTR in the study published in the New England Journal of Medicine by Julian Gilmore. And the next 23 patients were recently presented at the American Heart Association only a month ago. So this is just a summary to remind ourselves how CRISPR-Cas9 technology works and what its role is in this disease. And this is the paper where they show the results of the first 36 patients for 12 months follow-up with this phase 1 study using this NextZ technology. And you can see, wow, I mean, these patients, they have almost complete knockdown of their TTR level after 1 dose. And you can see from start the change in serum TTR level from baseline. We have stability of biomarkers and some improvement in functional class in this early study. And again, we have stability of echocardiographic parameters with this early study. Finally, I'd like to move into monoclonal antibodies. Why are these important, especially when we've got things like gene editing, gene silencers? Well, the depleters come at the other end of the spectrum. If you've got advanced amyloidosis, and we heard beautifully that if you've got advanced amyloidosis, you might improve a little bit, but not as well as those patients that are diagnosed early. How are we actually going to get rid of the amyloidosis fibrils? So this is where the depleters come in. This is one study from Alexion using a depleter. So it's a human monoclonal antibody, and it actually is used to deplete the amyloidosis deposits. And you can see here that with this drug, you have all your macrophages that are activated that actually come in and are able to destroy the amyloid fibrils. And it's been likened to a garbage truck getting rid of all of the garbage. And one thing is that patients can be on a stabilizer like tafamidis, and it keeps them nice and stable, but it doesn't mean that their amyloid is cleared, whereas this drug will clear it in addition to the stabilizer. So it will be very exciting to see the result of this Alexion study. The primary endpoint is occurrence of all-cause mortality and cardiovascular clinical events up to month 48. And this trial is actively enrolling at the moment. And then the second depleter comes from Novo Nordisk. And again, it's a human monoclonal antibody. And it targets the non-native transthyretin aggregates. And again, it's suitable for patients with advanced disease because it's aimed at depleting the amyloidosis deposits. So I've been asked to give you a sneak peek into the future. I think that what's important is that there is a lot coming, and that the technology in this space is rapidly developing. So we have to be, as clinicians, we have to be across early diagnostics, and then we have to be across the range of therapies. And we have to keep on asking good questions because all of the answers are not available to us yet. And some of best practice is going to be limited by availability and cost of drugs. And so we need to understand the landscape in order to best serve our patients. So with that, I'll close the talks for today, and thank you very much for your attention.
Okay, thanks, Nikki. So we have had 3 wonderful lectures bringing us through the whole management spectrum of transthyretin amyloid cardiomyopathy. So please feel free to enter your questions in the chat box, and we'll address the questions, if time allows. So please, any questions at all from the audience? If not, maybe I will ask a very important question that has cropped up many times in our clinical practice, I'm sure. So may I direct the question to Chunyuan. So we know that amyloidosis, transthyretin amyloidosis can be a hereditary problem, and we advocate family screening for all patients diagnosed with ATTR-CM. So there will be invariably a group of patients who are gene positive and they have no clinical heart failure or polyneuropathy symptoms. They are anxiously waiting for something to be done to them. And at this stage, what can we offer, and how do we decide when to initiate treatment? I know this is a very difficult question, but patients who of gene carriers have been asking me the same thing for a few years now. So what's your approach to managing this group of gene carriers?
Thanks, Wei Qing. So super difficult question. Lots of gray areas. But first, for positive gene carriers without symptoms, we would in general do cardiac imaging as well as letting them see a neurologist just to screen for any early disease. And if they have any recent carpal tunnel surgeries, for example, or lumbar spinal surgeries and tissues are available, we would in fact request to see if the lab could check for amyloid deposits in them, because these orthopedic manifestations are known to precede the cardiac and neurological manifestations by about 5 to 10 years. I know that there are some centers, if there are orthopedic manifestations but no cardiac or neuro manifestations yet, some centers are in fact giving diflunisal to these gene carriers with amyloid deposits in the orthopedic, with orthopedic involvement to kind of hope to retard the progression, but this is of course off-label. After that, then if cardiac screening and neuro screening is clear, there is no orthopedic manifestation, then of course every 1 to 2 years follow-up. Imaging in terms of cardiac MRI or PYP scan could be performed every 3 to 5 years for the heart, but no hard and fast rule, of course. And at any sign of early involvement, we would then hope to start the patients on amyloid-specific therapy. Currently in Singapore is tafamidis, otherwise it's diflunisal. I know that there is an upcoming trial which will be coming to Singapore as well for the study of stabilizer, a tetramer stabilizer, to be started in gene-positive asymptomatic patients to see how they perform against patients who are on placebo. So we really look forward to that upcoming study, and the results of that will provide a greater information to the community. yeah, I'm also interested to hear what the rest of the panel and yourself think of this difficult question.
I think there's no guidance on managing this group of patients. So please, our panelists, and everyone, please chip in. What would you say to the patient, or what would you do in managing, patients' expectations? Novi, anything you say?
Yeah, it's very difficult. I think currently in our country we don't have like any specific treatment for ATTR except for doxy and the flunitrazole. So generally, what we do is basically if we need to do a close surveillance for the patient, that's probably the best thing to do temporarily.
And what kind of surveillance? MRI, CT scan, sorry, not CT scan, nuclear scan or echo? What's your practice?
Yeah, yeah. Generally, our CMR wait list is quite long. It generally takes 2 to 3 months. So basically, for surveillance, we just do a very advanced. We just do an advanced strain echocardiography to monitor the progression of the disease.
And maybe Nikki, maybe I ask you a quite difficult question. How about family planning? How do you advise gene carriers about having offsprings? Are there any conception, for example, counseling that you routinely send the patients for? Because we know that it's potentially 50% chance of every child of theirs having this condition.
Yeah, Dr. Lin, I mentioned that we have to ask the difficult questions, and you've really taken that mantle and continued on with that. I think that this is a evolving space. The first thing to say is that, you would go through the appropriate counselling with the patient, and you would take a very detailed family history and a detailed family tree, and you would need to understand, their variant and the penetrance of their variant. So I would want to know what age they were diagnosed, and what age their family members were diagnosed. I think the kind of pre-implantation, particularly as more and more patients are utilising embryo freezing and then pre-implantation genetics, it very much varies by country in terms of what you can do, particularly TTR, and it's very, very individually determined. This is not a disease that's going to be diagnosed in infancy, and we now have therapies available, particularly an unborn child, by the time that they are older, and the time at which their disease is penetrant, we understand that we will have therapies available that will be disease modifying. So, as even we've been talking about, would you offer someone who's genotype positive but who's got no symptoms therapy? Well, that landscape is going to change in the next 5 years. So I would say this is it comes back to very close patient counselling and kind of watching the landscape as it evolves.
I think I absolutely agree with everyone. The landscape is evolving. We are trying to push for earlier and earlier treatment. And for all you know, in the future, when we have a child born with a mutant TTR gene, we might even infuse them with this gene editing therapy so that they'll never develop the disease. So for gene carriers who plan to get pregnant and get children, maybe that is something more optimistic for them in the future. Maybe there will be some treatment for their child before they even progress to having the manifestation of the disease. So that's a very exciting field to look forward to. So let's answer some questions from the audience. I have a question over here from Perrin, who is currently at St. Vincent's. Any biomarkers that can be tested from blood tests in the pipeline for monitoring disease activity or response to treatment? So currently we know that we do staging for TTR using the NAC stage. We use just eGFR and BNP. Maybe I ask the panel, do you do a staging for every patient at diagnosis and on follow-up, and what do you make of all these biomarkers?
I'm happy to go first. So the conventional biomarkers, troponin, BNP, and then, as you mentioned, EGFR, we would do routinely in everyone at baseline, and then we would follow them at their next visit, particularly if we've started treatment. We know that patients who are treated with something like tafamidis or another agent, they should have stable biomarkers or improving biomarkers. And if those biomarkers were deteriorating, I would worry why this is the case and if the therapy is not working. In terms of novel biomarkers, I feel really excited about, as a clinical marker, frailty, so the clinical frailty index, because I think that our patients are in general older and have a multimorbidity, and frailty is something that plays into decision-making in amyloidosis. And then in terms of novel other markers, I'm really excited about neurofilament light chain. I think that there's evolving evidence that it helps us diagnose patients with neuropathy early. And we know that neuropathy occurs often prior to cardiomyopathy. So I think that this is a really interesting space in which we can potentially diagnose disease earlier and also follow progress.
Thank you. So, Chun-Yan, you wanted to say something just now. Sorry.
Oh no, I complete. So Nicole I think has very nicely summarized all the biomarkers that we currently use and the upcoming neurofilament light chain.
Yeah, absolutely. So maybe we can move on to the next question. How do we differentiate patients according to their clinical phenotype? Would we preferentially start treatment with one agent over the other for patients with predominantly cardio symptoms or neuro symptoms? Maybe I get some opinion from Chun-Yan. What do you think? Do you preferentially give one drug over another based on patients' clinical phenotype?
So in the real world, we are limited because we currently have available tafamidis and diflunisal. The silencers are extremely expensive and on a case-by-case basis. So in patients, for now, in Singapore, regardless of predominant cardiac or neuro phenotype, in general, they would be started on tafamidis. Because there is evidence in cardiomyopathy. There's also some evidence in neuropathy for tafamidis. Of course, in the future, when silencers become available and when silencers are proven in cardiomyopathy, then it might be an exciting field, because then, as Nicole mentioned, it's currently unknown who would be the patient who would benefit from one therapy over the other, or does combination therapy work better for some others? But this is assuming that everything is affordable to the patients. So for now, both neuropathy and cardiac manifestations in Singapore, we would be giving tafamidis. Of course, if everything is available, then perhaps for more cardiac phenotype, tafamidis, for more neurological phenotype, then the silencers with the current evidence.
Nicole, Novi, what do you think? Do you agree with such an approach, or do you have, any views on dual therapy upfront, tafamidis plus a silencer?
Yeah, I think there's some guidelines mentioned that we can start both of the like, for example, if there is only cardiomyopathy, because tafamidis generally work as for cardiomyopathy, and there is I think the latest ESC position paper on the cardiac amyloidosis mentioned that we actually can start on both combination therapy, but of course it depends on the resources and the area of the region, because currently in our country we don't have. So if we need tafamidis, we need the patient, we need to send the patient to Singapore or Malaysia to get the drugs anyway.
Currently in Singapore, as far as I know, there are only 2 patients on gene silencer therapy with patisiran. So it's very limited in this part of in my country as well. For a country with no limits on healthcare expenditure, what's the landscape like in US, Nikki? How do the Americans practice nowadays, where there's sort of like a buffet of treatment options available for mixed phenotype patients?
Cost is still a limitation. So, you know, it would be very rare for a patient to be tafamidis naive. You know, when you think the US compared to Australia, we only got tafamidis on our pharmaceutical benefit scheme May 1 this year. So, you know, we still have tafamidis naive patients who are being referred, whereas the US, you know, patients are worked up and already on tafamidis, which are that more well cohort. But they are, you know, with kind of insurance and the different, you know, the interesting landscape that is the US medical system, there are more and more patients on dual therapy, but, you know, it's really important to mention that therapy is extremely expensive. The other thing to say is, you know, BridgeBio, they were able to, in their open label extension, they were able to provide medication to anyone that was in their trial, which is a new approach. And it means that patients have access to therapy that's now FDA approved. So, you know, that may be something that other drug companies follow suit.
Okay, maybe we can move on to the next question. There's a audience question over here. Any experience with current therapies in, you know, neurological symptoms improvement? I mean, we are cardiologists, but we do have a cohort of patients with mixed phenotype. Anyone have experience managing these patients, and whether any therapy at present have shown to improve neurological outcomes for our hereditary or mixed phenotype patients? Maybe I can start off by saying we do have some neurological trials, and I think neurology is more advanced in the field of treating amyloidosis than us by maybe a decade. So most of all medications used in cardiac amyloidosis were tested earlier in previously it was called familial amyloid polyneuropathy, including patisiran, inortacin, and this silencer medications have been shown to have slight improvement in neurological measurements. But of course, in neurology, often they measure you know, neurological outcomes and not heart outcomes like death, cardiovascular events. But there has been some signs, some signals that inortacin, patisiran do have slight improvement in neurological function in patients with mixed phenotype or purely polyneuropathy kind of phenotype. So, well, the answer is not so clear, but if patients can afford the medication and they have predominantly neuro manifestation, regardless of their cardiac condition, I think we can consider a gene silencer therapy. Let's look at the next question. In the distant future, when gene silencing therapy is safe and effective, maybe monoclonal therapy is useful to mop up the amyloid fibrils. That is what Nikki said in her lecture. What is your hope in the future, Nikki, about these monoclonal antibodies in clearing up the fibrils that has already been deposited in the end organs? Do you think that it will be an add-on therapy? What's your hope?
I think it will be an important space for patients with advanced disease. So, you know, my hope for the future is that patients are diagnosed early. We don't have these patients with advanced disease. Potentially, there's less of a role for kind of mop-up therapy. But at the moment, we're still seeing patients with, you know, New York class 3 disease, class 4 disease with amyloidosis that is, you know, distributed in all 4 chambers of the heart. And this mop-up therapy, we know that tafamidis is a stabilizer, and we know that these patients still deteriorate eventually. And so I think that mop-up therapy absolutely has a role for advanced disease. And again, it will take trials where you're seeing patients in combination. So, you know, already with the different trials of monoclonal antibodies, they're going to allow patients that are already on tafamidis. You know, I'm not sure how many patients will be on other agents, but that will be the future where you have gene editing plus a monoclonal antibody for us to actually understand what that outcome for those patients are.
Yeah, I think the future is exciting, but things will be very, very complicated with all the options available. For example, if we start a patient on a gene editing therapy, is there a role, to give stabilizers anymore because there are very, very low levels of TTR left in the serum. So whether we need to get another expensive therapy, to families or agromedists for these patients who undergo gene silencing treatment, that is controversial. And what about mopping up of the fibrils? Will there be a test in the future to look at amyloid load to decide on whether these patients require antibodies to mop up these amyloid deposits in the end organs? So that is something very, very exciting to look forward to. And maybe one last question from the audience. What is the prevalence of asymptomatic cardiac amyloidosis in elderly, geriatric population? Maybe I direct the question to Novi. Do you have any epidemiology data to say what's the prevalence of this condition? And specifically, I think the audience member wants to know asymptomatic cardiac amyloidosis. Do we have any epidemiology data?
Yeah, I think there is some study reported there is a around above 70-year-old the asymptomatic patient with CA is around I think 21.5%, I think, in some study.
Yeah, so I agree. So there was a post-mortem study looking at very elderly patients, and they indiscriminately looked for amyloid fibrils in their heart. And I think the statistics might be what Novi said, about 20% of all these very elderly patients with no history of amyloidosis diagnosed actually do have amyloid fibrils deposits in their heart. So what then is the cause of all this fibril deposition? Is transthyretin cardiac amyloidosis just an aging thing? And if we all live long enough, we are going to have transthyretin cardiac amyloidosis? I'm not sure. And I hope more data in the future, more epidemiology studies in the future will shed light on this. But I think we have, that's all the time we have for today. We have come to the end of a very exciting, very interesting three-part lecture series on cardiac amyloidosis. And I'm very happy to have more than 100 participants at each lecture. And we thank again all our wonderful panelists, our speakers, for this very engaging, very interesting lecture episode. So please scan your QR code on the screen now for the feedback. And after the feedback, you'll get, I think, a certificate of attendance. So once again, thanks everyone for attending this amyloid cardiomyopathy lecture episode. Thanks Novi, thanks Chun Yuan and Nikki for your wonderful lectures. Have a good Saturday afternoon, everyone. Thank you very much. Bye-bye.